Bismillahirrahmanirrahim. Today we are going to discuss about carcinoma of the larynx. So these are the different headings which we will discuss. As you know, larynx is a voice box in the neck. It has three portions: supraglottis, glottis, and subglottis. The vocal cords, true vocal cords, are part of the glottis. The incidence: this is the most common cancer of head and neck region, and it is 4 times more common in males, and more than 90% it is always squamous cell carcinoma. So you know, the squamous cell carcinoma is of epithelial origin. It is the squamous cell carcinoma, as you all know, it is the most common tumor of the epithelial region. And as I told you, glottic carcinoma is the most common. It is common in Caucasians, while in African Americans, glottic and supraglottic, they have equal incidence. So main risk factors, as you all know, are smoking, alcohol, and human papillomavirus infections. Subtypes: you see this glottic carcinoma, it is mostly 60% are glottic carcinoma of the vocal cords. True vocal cords के ऊपर carcinoma, this is most common one. Then after that is the supraglottic carcinoma. It is about 40%. And the least common is subglottic carcinoma. Early stage, when there is chronic irritation of the larynx and chronic infection, so there is change in the epithelium, there is metaplasia, and there is leukoplakia, whitish band over the vocal cords. It is an early sign of development of carcinoma. It is a pre-malignant condition, leukoplakia. It has a potential to get converted into carcinoma anytime. It is stage 0. Then stage 1 is when it is converted into squamous cell carcinoma, first stage, limited to only one vocal cord. Now this tumor has now gone out of the glottis. It is coming into the supraglottis as well as going downwards. So now it is an advanced cancer. These are different stages of the larynx, stage 1, 2, 3, 4. In stage 1, the tumor is present only at its origin. Like if it is a glottic carcinoma, it is only in the glottis, stage 1. If it goes into supraglottis or subglottis, then it becomes stage 2. And when it involves the surrounding structures around the larynx, it becomes stage 3. And when it goes outside the larynx to other structures, then it is stage 4. It also includes metastasis to other parts of the body. So when patient comes to us with hoarseness of voice, a patient may come with hoarseness of voice, with change in the voice, difficulty in breathing, cough, dryness in throat. Then patient, if he is a smoker or if he takes alcohol, then we should take a complete history. Then we do examination. So if patient age is more than 40, 45, then we should rule out tumor. So on examination was, first we examine complete ENT examination, head and neck examination. Then we do indirect laryngoscopy, or if available, we will do fiber optic laryngoscopy. We will see the condition of the larynx, the condition of the vocal cords. Is there any mass or any suspected lesion in the larynx? And we will, if there is suspicion, then we will take biopsy of that. So these are the normal vocal cord, and this is the tumor on the right side. So we will take biopsy of this, and then we will send this biopsy for histopathology. When the histopathology report will come, then we will decide what is the treatment we are going to do. Another advanced tumors on the left vocal cord. So but after taking biopsy, we will also do CT scan of the neck, head and neck region. Why we do CT scan? Because we have to see what is the extent of the disease, and what is the stage of the disease, which structures it is involving, what is the size of the tumor, and what is the if is there a tumor is going into the neck nodes. So we want to stage the tumor. So for that, CT scan head and neck with contrast is done for proper staging of the disease. And some surgeons also do CT scan chest along with the CT scan head and neck region, because sometimes there may be a second tumor in the lungs. So I prefer to do CT scan head and neck as well as CT scan chest, because if there is any second tumor, we should also address that as well. And it should always be done with contrast, with and without contrast. We want to see if there is any lymph nodes involved in the neck or not. So before treatment, as I had told you, we will do staging of the tumor, what is the stage, which structure is involved, and then we will discuss with the patient or their attendants about the different modalities of treatment that we have. There are different types of treatment available, like there is surgery, there is radiotherapy, there is chemotherapy, then there is chemoradiotherapy. It all depends upon what is the type of the tumor and which stage the patient is presenting to us. If the tumor is stage 1 in the larynx, so then we will go for radiotherapy, because mostly the tumors of the larynx, they are very radiosensitive tumors. They respond very good to the radiotherapy, and patients survive for many years after just simple radiotherapy. They are completely cured. So radiotherapy is the first option in early cases of laryngeal carcinoma, because an important function of the larynx, as you know, is the voice. So when you want to remove the larynx, obviously the patient will lose his voice, which is very disturbing for the patient to lose the voice. It is a big decision, and for the surgeon as well as for the patient, both. So you have to take very cautiously, you have to decide when to remove the larynx. So we discuss with the patient. So what I was telling you about different modalities. Initially, if stage 1, stage 2, we like that we want to preserve the larynx, we want to preserve the voice of the patient, so we prefer radiotherapy. But if it is then chemotherapy can also be done, or targeted therapy can be given. But if stage is advanced, then we can go for surgery. The radiotherapy has good results, I told you, in initial stages, but it has some side effects, but these side effects are temporary, and they settle down after the radiotherapy is over within few weeks. This is how the radiotherapy is given. And chemotherapy in advanced laryngeal cases or recurrent cases. Obviously, they have also side effects, but they are also reversible. Then targeted therapy is given few selected cases. It is more specific than chemotherapy. Like cetuximab is being used for laryngeal cancer. Now surgical options, I told you if the patient tumor is advanced but still in the larynx, and we can do surgery. We can do with laser or we can do direct surgery. There are different options. If in early tumor, we can do transoral nasal microsurgery. But if it is advanced tumor, then we go for laryngectomy. Laryngectomy has two types, partial and total. The partial laryngectomy has some reservations. Partial laryngectomy is a difficult procedure and there is a chance of recurrence. So some surgeons advocate total laryngectomy at first hand. So in total laryngectomy is done in third or fourth stage patients in which the partial laryngectomy cannot be done because there is a chance that the tumor will be left behind. When there is involvement of thyroid and cricoid cartilage, we do total laryngectomy. Or if there is invasion of the neck soft tissue, we do total laryngectomy with neck dissection. This is the total laryngectomy specimen. Because I told you it is a procedure in which the voice of the patient is lost and then there is permanent stoma formation in front of the neck. For whole life the patient has to breathe through this hole. So it is a big decision for the patient for total laryngectomy. But patients are surviving for many years, for decades with this stoma if it is treated timely. The main concern of the patient is about voice restoration. There are different options so that patient can start speaking. Patient is told exercises and he can develop esophageal speech with practice later on. Or sometimes we do tracheoesophageal puncture and then patient can speak through that puncture hole. And then there is an electronic device called electrolarynx which can be used to speak. This is the esophageal speech. The patient generates air through the esophagus and then esophageal walls vibrate and patient speaks. This is called esophageal speech. With good practice, it can be done easily. Then this is the tracheoesophageal puncture. See this? And a voice prosthesis is placed there. So we were discussing about tracheoesophageal puncture. This is a small prosthesis device in the puncture and patient can speak through this. This is the electrolarynx. It is an electrical device. It can be placed on the neck and patient vibrates the tissues inside and speaks through this voice. So these are different methods of voice restoration in the patients. So if you have any questions regarding carcinoma of the larynx, you can ask in the question sessions. Thank you.